Participating via Zoom. It is 1 o'clock. We'll proceed with the call to order and roll call.
Senator Alvarado,
Here.
Senator Carroll, Senator Higdon.
I'm here remote.
Thank you. Senator Higdon, Senator McGarvey.
Here remotely from my office in Louisville.
Thank you. Representative Gooch.
Here in my annex office.
Thank you. Representative Prunty.
Here via remotely.
Thank you. Representative Sheldon.
Here remotely.
Thank you. Representative Wilner.
I'm here in the 35th District.
Thank you. Senator Meredith.
Present.
Representative Elliott.
Here.
Thank you.
Thank you. We do have a quorum.
Mr. Chairman,
Yes.
this is Jimmy Higdon. Can I answer roll call? I was on mute.
Most certainly, Senator Higdon. I know how you're technically challenged sometimes with all this new technology. So, yes, we'll record you as being present, sir. Appreciate it.
Thank you, sir.
Thank you. We have a rather lengthy agenda today. A lot of territory we're going to cover. Very ambitious agenda. So we'll try to move through it as quickly as possible. Certainly you folks who are doing this remotely, if you have questions, we have the chat function. But if you're overlooked for whatever reason, feel free to speak up and let's make sure we have everything covered. Again, I remind you this is the first meeting of our interim. And I'm sure a lot of information will be shared with us today. And rather than getting the minutiae of the detail, we probably want to keep in mind that we can defer some of this to future meetings to get into more detail. But with that, I'd like to jump right into the agenda. You have the minutes which were previously distributed. Is there a motion to approve as presented? Motion by our co-chairs or second?
Second.
Second, Senator Alvarado. All those in favor of the motion vote aye. All opposed vote no.
Aye.
Any opposition? My like sign.
Aye.
All right, thank you. Minutes are approved. First item on our agenda is update from the Advisory Council on Medical Assistance. And I believe Ms. Barton is here. She's testifying remotely, I believe.
Okay, can you hear me now?
Yes, we can. Thank you. Please proceed. Appreciate you joining us this morning. Or afternoon, excuse me.
Thank you. Good afternoon. My name is Dr. Beth Parton. I'm a nurse practitioner representing the nursing the Nursing on the Medicaid Advisory Council, and I currently serve as chairperson. I'd like to thank the committee for the opportunity to update you on some of the issues before the council, or as we're commonly referred to as the MAC. Due to the COVID pandemic, the last in-person meeting of the MAC was January 2020. We didn't meet again until September 2020, and that meeting and subsequent meetings have been virtual. My update to you will include the issues we have dealt with in 2020 and 2021. At the MAC meetings, DMS provides information requested by the council, provides presentations on various topics related to Medicaid, and the commissioner provides updates to the MAC. The council also receives information annually from each of the MCOs when they provide a report. The MAC requested these reports a few years ago. Not only do the reports from the MCOs help the MAC members stay informed, but also it allows an opportunity for members to ask questions, report problems, and seek remedies to concerns. Commissioner Lee has made an effort to seek input from MAC members, and two recent examples are that she requested input from the council on items to be included in the state plan amendments to incorporate changes made under emergency orders that would be submitted to CMS. And she asked for input to the problem we have in Kentucky related to infant and maternal morbidity and mortality. The MAC provided input on both topics, and it was well received. On the issue of infant and maternal morbidity and mortality, the MAC was pleased to offer advice and to make a number of suggestions. And because this issue is a big problem in Kentucky, I'd like to take this opportunity to present some of the suggestions we provided to DMS to this committee. In 2018, 1 in 11 babies in Kentucky were low birth weight. Kentucky did not meet the Healthy People 2020 objective of no more than 7.8% of births to be low birth weight. The MAC suggestions included extending Medicaid reimbursement to certified professional midwives or CPMs. CPMs are licensed and regulated by the Board of Nursing and can help to improve access to prenatal care. Improved access to prenatal care equals more healthy moms. Support Senate Bill 92 and Senate Bill 76, which were introduced in the 2021 legislative session to remove certificate of need requirements for freestanding birthing centers. Data shows that birthing centers improve access to prenatal care, reduce the rate of C-sections, and reduce the cost of care to Medicaid. One study showed about $2,000 per birth in savings. Increased efforts to help pregnant women quit smoking. Smoking leads to low birth weight babies. Remove the mandate to report marijuana positive mothers. Possible positive tests prevent women from seeking care in the first trimester, which is a crucial time to help ensure a healthy pregnancy. Coordination of prenatal care through the health departments. This would assist both the urban poor and rural mothers. Many rural communities do not have OB care, and there is a health department in every county. DMS to connect with the Perinatal Quality Collaborative. Support House Bill 212, sponsored by Representative Heverin, to require the Child and Maternal Fatality Annual Report to do a demographic analysis by race, income, and geography, and require the annual report to be sent to the Interim Joint Committee on Health, Welfare, and Family Services. The MAC was pleased to see that this bill passed in the 2021 session. At the March MAC meeting, DMS provided a presentation to address the incorporation and the recommendations made by the MAC and provide more information about what DMS is doing to improve the health of mothers and babies. And an update on DMS progress will be given at the November MAC meeting. Other information provided to the MAC this year have included presentations on the Kentucky Health Information Exchange, or KHI, the Hospital Reimbursement Improvement Program, and the MCO and the MCOs, and updates on Medicaid regulations and MCO contracts. The commissioner announced at the March MAC meeting that DMS would start providing a presentation at each MAC meeting on different parts of the department so that members may be better informed about Medicaid. One issue brought to DMS by the MAC was a problem related to reimbursement for more than one medical visit per day for Medicaid recipients. Transportation for Medicaid participants can be a problem, and people will often group medical appointments in one day. For instance, a person may schedule an appointment with their primary care provider and with their psych provider in the same day. In the past, only one of these providers would be reimbursed. DMS has fixed that problem, and now participants may see more than one provider in a day. The MAC and TACs have long requested a single drug formulary to be used by Medicaid and all the MCOs. Differing formularies caused confusion and delay in receiving medications. DMS has now implemented a single drug formulary, which is a step in the right direction. However, some problems related to the change have arisen. Medicaid recipients were supposed to be grandfathered to allow them to stay on their current medication, but that has not yet happened. This is a particular problem for patients with mental illness who are told medication is not at the pharmacy because of a glitch. These patients may not return to the pharmacy later to get their medication, leading to serious consequences such as involvement with the criminal justice system or hospitalization. Also, in some cases, generic medications are no longer preferred, which reverses a long-standing policy. This requires providers to switch medications or rewrite prescriptions. Since DMS has responded to the long-sought single drug formulary, the expectation is that DMS will work with the MAC, TACs, and providers to remedy these issues. Other regulatory changes sought by the MAC that have not been made, but the commissioner has indicated that the department is willing to consider, are to amend 907 KAR 1:082 for rural health clinics to extend the time for providers to sign off on patient charts from 1 day to 3 days. And this would be in line with all other regulations, and add certified professional midwives as providers reimbursed by Medicaid. I'd like to say that Commissioner Lee has been forthcoming with any information the MAC requests and has engaged the MAC in an advisory capacity, which is a welcome change. Thank you, and I will be willing to answer any questions.
Thank you for your report, Dr. Parton. Very thorough, very comprehensive, and just remind the committee members that I think until year before last, Mac and I routinely reported to this committee, so we appreciate you bringing us up to speed, and certainly helps us focus on what we need to do with the upcoming session. But you certainly have covered a lot of area. Are there any questions for the committee members? Senator Alvarado.
One very brief question. Thank you for that presentation. Some of the comments you made in there caught my attention, one of them being the marijuana use during pregnancy, not wanting to report that for fear of deterring people from coming out and getting prenatal care. Obviously, there's a reason why we want to make sure that we know who's receiving marijuana during pregnancy. And I'm wondering if the committee has reviewed the data and all the negative outcomes that can happen to a baby who's exposed to THC during pregnancy. I mean, I'm looking right now here at Massachusetts General Hospital for Women's Mental Health, talking about the use of marijuana, the side effects, the risks. It's elevated risk of miscarriages, birth defects, developmental delays, learning disabilities in kids who are exposed to this. And obviously it gets stored, it has a half-life of 8 days, gets stored in fat for 30 days. So even just a minimal use by some mothers can linger in their bodies, and babies get exposed to that during their entire embryonic development. Was that reviewed by the committee to say that we want to make sure? I mean, that's astonishing to me. I just know the negative effects that it can have on a baby and the outcomes, the long-term effects it can have. To say that we don't want to have that encouraged, that they don't, for fear of them not coming forward and getting care. We need to make sure that we have an understanding of what's going on during a pregnancy with negative outcomes, not only for moms, there's also higher risk of ectopic pregnancies, impairment of fallopian mobility, all kinds of things that can happen during a pregnancy with that exposure. I would think we'd want to have as much information as possible. We don't restrict mothers from telling us their smoking status or tobacco use status with all the negative outcomes that can come from that, knowing what we know about marijuana. I'm curious if the committee has reviewed that or not.
Oh, I don't disagree with anything that you've said, Senator Alvarado. The point being that they would not have to be reported as using an illegal substance, not that they would not be asked about it by their provider.
Is that being reported now? I mean, as far as if mothers are using that, I'm not aware of any medical provider in the state of Kentucky, anything that's discussed privately in a medical setting, that anyone says, oh, you're using something, I'm going to report that to the authorities. No one does that in the medical profession. I don't think we're allowed to unless that patient permits us to do that. So I'm a little surprised that was brought up and that was a recommendation, because if someone comes into the office and says, hey, I'm using cocaine or I'm using anything that's an illicit drug or an illegal drug, we don't rush out and call the police to tell them, hey, I've got a patient here who's using that. It's all confidential information in a medical office. So I don't think it'd be a good idea to discourage any of that information coming forward. We want to make sure that our patients feel comfortable that the information they tell us in a medical office is private. No one's reporting that to the authorities or the police. And really, if they are, then that's a violation of their ethics, and they can get in a lot of trouble as a medical provider for doing that. But that's something that needs to be known. I mean, that has negative outcomes for moms, for pregnancies, and for babies. And that's my only comment. Thank you, Mr. Chairman.
Thank you, Senator Alvarado.
And I don't disagree at all with that.
Any other questions from the committee members? Representative Sheldon, you have a question?
Yes, thank you, Senator Meredith. Thank you, Ms. Parton, for presenting today. Just want to ask a quick question. Did you all offer any guidance towards the methodology and logic to be used for Senate Bill 50 and the pricing and dispensing methodology, I guess I should say? Sorry. Did you all provide anything to the cabinet concerning the methodology of how to implement Senate Bill 50?
No.
Okay, thank you.
Any other questions? If not, I have a couple. First, has there been any follow-up with your committee on the issue of the RAP payments, crossover payments for FQHCs or rural health clinics? I know that's been a lingering issue for several years now.
There have been recommendations from the primary care tech to the MAC on those issues, and the primary care tech is working with DMS on that.
Mm-hmm. So no resolution at this point that you're aware of?
No.
Okay, thank you. Other question I have is regarding the low birth weight initiative. I certainly commend the MAC for that. I'm just curious as to what data is available? And is it good data? I see we're undertaking several initiatives here, but sometimes I'm concerned about us taking an approach, and I'm not suggesting you folks are doing this, of throwing Jello up against the wall and hoping something sticks. Do we really have any definitive data that tells us what the primary issues are with regard to low birth weight? You made mention to access to care. Certainly that's always an issue, but is that the most pronounced issue that you have seen?
That is one of the big issues as far as access to care, that is a problem in rural and urban areas. I don't think that anybody has zeroed in on why that's a problem, particularly in urban areas where there is readily access. The Department of Medicaid Services provided an excellent presentation to us at the last meeting, reviewing all the recommendations that the MAC had made, and also talking about some of the things that DMS is doing and is planning on doing. And I would be glad, or I guess the commissioner would be glad to also provide that presentation to you. And I think, Commissioner, isn't that available on the DMS website right now?
Yes, I'll present.
She's shaking her head, yeah.
Yes.
So that was an excellent presentation, provided a lot of data, and also provided information on the data that we don't have and that we need to get.
All right, thank you, and appreciate that.
I think that Representative Hebron's bill is a good step in that direction.
Mm-hmm. Do you think Representative Heffern's bill obviously fills a void, or were we without sufficient information, do you think?
Yes, I think we did not have sufficient information, and I think that her bill is a good step towards getting information that we do need.
All right, thank you. Any other questions from committee members, both present and virtual? If not, Dr. Parton, appreciate your presentation today and joining us again, and look forward to our future dialogue with you. Thank you.
Thank you. If it's all right with you, I'm going to sign off and get back to work, if that's okay.
Most certainly. Thank you. Appreciate it.
Thank you so much.
I think the balance of our agenda is going to be with Commissioner Lee, and glad to have you join us this morning, or this afternoon, sorry. A lot of territory we've asked you to cover, and we appreciate your indulgence of our committees. But it's been a while since we've had a chance to talk, and so we'll let you jump right into it. The first item is the update on the impact of COVID-19 on our Medicaid program. So with that, if you'll jump right into it, we're all ears.
All right. Thank you so much. And again, I'm Lisa Lee. I'm the Commissioner for the Department of Medicaid Services. And I believe that, do I have permissions to share my screen so that we can go over the presentation? See if I can. Okay. Are you seeing the presentation, or?
I'm seeing a presentation. The first slide I see is a mandatory fee for service expenditures.
Now, what do you see?
I see your cover, Medicaid Oversight Advisory Committee, your cover page.
All right. I think we're good to go then. Here we go. Again, Mr. Chairman, we do have quite a few topics to go over. So would it be your preference that I stop after each topic and ask answer questions, or go through the entire presentation and then stop for questions?
Well, my original thinking was to let you go through all of it and then entertain questions, but we've got so much territory to cover. I'm afraid some questions might fall. So let's do that. Let's start with do it topic by topic and open it up for questions if we could.
Okay, I know it's a lengthy presentation, but I think I can hit the highlights on this for you. I just wanted to give you all as much information as I could. And the first topic, of course, being the impact of COVID-19 on the Kentucky Medicaid program. As we're all aware, I wanted to show you that we have increased our enrollment in Kentucky quite significantly. As you can see, there is a national growth in all Medicaid programs during the COVID emergency period. Kentucky, there's a little blue arrow right here that indicates that Kentucky's about third down in enrollment. We have significantly increased our enrollment. We are only behind Oklahoma and Utah. Here is a chart. I know these numbers are quite small. You may not be able to see all of them, but this highlighted row is March of 2020. That is when the public health emergency was declared. At that time, Kentucky had 1.3 million individuals enrolled in the Medicaid program. Currently, we have 1.6 million individuals, and we have broken this out by children and adults so that you can see that we have we've also increased approximately 52,000 children in the program, which I think is important when we start talking about service utilization. So this is just a depiction of the enrollment trends in the adults, and the blue line is children. So you can see that we have increased that enrollment of children as well. So some key takeaways from the enrollment, the impact COVID had on our enrollment, of course, is that we have enrolled an additional 52,797 children. This increase in enrollment reflects changes in our economy. Individuals have lost their jobs, or they have reduced incomes if they're a two-parent or a two-person household and one person lost their job. Medicaid expansion was very beneficial during the during this pandemic, because the majority of our increase is in adults between the ages of 18 and 65. We do have a maintenance of effort in place that is required at the federal level, that we cannot decrease enrollment. Anyone that is enrolled can only be disenrolled if they leave the state, or they die, or they ask to be disenrolled. Based on that maintenance of effort, we continue to qualify for our 6.2% increase in FMAP, which has been very beneficial in helping us remain within budget during the public health emergency. The Affordable Care Act Special Open Enrollment Period is running through August 15. Some of those individuals who may have been on Medicaid and now maybe are returning to work or do not qualify for presumptive eligibility can enroll in the special enrollment period and also receive reduced premiums during this time frame. Wanted to talk a little bit about our service expenditures. We have been monitoring payments to providers based on their provider type. We've been looking at pre and post COVID. So this first slide is all about mandatory fee-for-service expenditures. The first column depicts the expenditures from July 2019 to February 2020, and again from July 20 to February 21, to just give us a little idea of what happened during COVID. And as you can see, we've highlighted some of these areas. We did have a huge increase. If this is in the fee-for-service again, huge increase in our laboratory expenditures, which is not really a big surprise. We did have an increase in dental expenditures and in outpatient hospital, physicians, and vision. These, again, are not a really big surprise, because we believe that some of those individuals were presumptively eligible individuals who had not previously had health care, and there may have been a little bit of pent-up demand. Again, nurse practitioner and midwife, 131% increase. That indicates that there were some pregnant women who may not have had health insurance. And so we're very happy to see that we could provide services to that population during the public health emergency. Just some takeaways. Again, I want to point out that the information depicted in that slide is based on date of service. We believe that gives us a better picture of the actual utilization patterns of individuals. The greatest increase, again, was laboratory. Decrease was non-emergency transportation. That is the stretcher transportation. That is not the transportation that is provided by our non-emergency medical transportation brokers through our contract with the Office of Transportation Delivery. A few other notable changes. You can see the increase in inpatient hospital and outpatient hospital. Again, no big surprises here. Vision, dental, again, fee for service. Here are the optional fee-for-service, same information for optional services. You can see again, ambulatory surgical center increased 148%. Chiropractor payments increased by 1,303%. A lot of these increases too could have been attributed to, or most likely are attributed to, the fact that we waived prior authorizations through a certain period of time for all of our provider types. Those prior authorizations have been reinstated, except for behavioral health and substance use disorder treatment providers. So you can see here, for example, we did have a pretty significant increase in our licensed marriage and family therapists. Also an increase in the mental hospital expenditures and nurse anesthetists. Always have a hard time with that word, but again, here's the remaining fee-for-service expenditures. You can see some of the increases. Again, residential crisis stabilization increase of 266%. Of course, that is, again, I think attributed to the prior authorization process not being in place and individuals definitely needing some of those services. We did see a decrease in school-based services. Again, most of those services are in person. So a slight decrease, pretty significant decrease in those services, and then a few others listed there. Again, some of our key takeaways, this again was based on date of service. The pre and post-COVID dates are indicated there, so you can see. Again, great increase in chiropractic services. School-based services were down. The CMHC, mental hospitals, ambulatory surgical saw an increase. Home delivered meals was an increase because some of our home and community-based waiver providers were going to see reduced revenues. So we did submit an Appendix K to the Center for Medicare and Medicaid Services, which allowed us to let those providers deliver those meals and provide additional services so that they could remain viable during the pandemic, and they received revenues. Again, the no prior authorization on the mental health or behavioral health and SUD is definitely, we think, attributed to the increases in the CMHC and the mental hospital. Now we get into the MCO and counterclaims. We've broken this out very similarly to the fee-for-service claims. You can actually see, there were some significant decreases in some of the payments, again, attributed to the lack of foot traffic in some of the offices. And then, some individuals, even though that we started doing the telehealth, we expanded telehealth, some of those claims may not hit the system. Again, this is based on date of service and not the date that we paid the claim. One particular issue you can see is the children with special health care needs. We see a decrease in that service. That is a particular interest to us, since we have seen an increase in child enrollment during the public health emergency. That means that some of these children who are very vulnerable are not receiving services or have diminished services during the public health emergency, which means they may have higher cost care as we go forward. So we definitely need to keep an eye on some of these services, because we do know that the public health emergency is going to have an impact on the future care of our children. Again, you can see in here a slight increase in the chiropractic services. Again, maybe the prior authorization process had something to do with that. Increase in the licensed marriage and family therapists, and an increase in mental hospitals. Again, this is just a continuation of the MCO encounters. Decrease in preventative services, which is, again, an indication of what we may need to look at in the future. If individuals aren't getting their preventative services, they may have increased healthcare costs as we go forward. Residential crisis stabilization unit has decreased. One of the biggest concerns for me, again, is the specialized children's services clinics. These are clinics that provide sexual abuse examinations for children. So again, the COVID has had an impact on the population that we serve, and particularly our children. And we believe that definitely going forward that we will see increased costs related to treatment of our population due to some of the issues associated with decreased utilization and decreased services provided to them. Again, greatest increase is licensed behavior analysts in the managed care arena, up at 118%. Crisis stabilization was down 78%, and preventive down 73%, which we think is significant. We do have a category called unknown. That could be, MCOs may be providing a service that we couldn't really directly relate back to our category of services. For example, they could have been providing a capitated payment to one of their providers or something like that, but definitely something that we can look at more in depth if needed. The LMFT saw a 23% increase. And again, all of that information we won't look at very much, but definitely want to talk a little bit about ER utilization. And I think that this is definitely something that we should continue to examine. We can see that non-emergent use of the ER went down during COVID. And this is just basically the same information depicted over age groups and by gender. But what I would like to do, what I think would be a good exercise is to examine the non-emergency use of the ER prior to COVID, and then kind of see, why were individuals going to the ER then, and then it's not increased as much. How can we basically identify and determine what, if any, interventions we can develop to ensure that individuals receive care in the most appropriate setting going forward? So in other words, how can we learn from this? What can we learn from this data and turn it into information that helps us drive those policies that ensure individuals get the care in the right setting at the right time? Routine child health exams. I wanted to just give this out again to show this, because again, we know that we have an increase in child enrollment. Prior to COVID, we had 174,168 distinct children have a routine child exam with no abnormal findings. That's really great. But now we're showing 146. And while our numbers are slowly creeping back up, there is a concern that some of these children maybe definitely did not get their routine vaccinations. So how do we reach out to those children and make sure that we get them in our program, get them the services that they need as we go forward? This is routine child health exams that had an abnormal finding. So prior to COVID, there were 62,943 children who needed to be referred to follow-up care after they had their routine exam. And so while we're seeing an increase in routine child exams, we're not yet back to our pre-COVID levels. So again, this is a little bit of a concern, because if we have children out there who should have been referred to corrective action or to a specialist and they did not receive that care, again, we may be seeing increased cost associated with the care of our individuals going forward. And we talked about telehealth just a little bit ago. This is telehealth MCO encounters. So individuals who utilize telehealth during this period, you can see that the largest cohort was age 18 to 40, which aligns with the new enrollment trends of adults between ages 18 and 64. And, this cohort probably is more likely to be a little bit more technology savvy and utilize those services. Now, this is the telehealth fee for service, and I want to point out, you can see this big spike here. These claims, as I talked to before, the claims were based on a date of service. The information that I had available to me in a report for telehealth was based on paid date. So if we spread this out over the date of service, it will look just a little bit differently. And the big spike you see here is because the school-based changed their vendor, and their claims hit on this paid date more in February than prior. So individuals who actually in the Medicaid program who actually had a diagnosis of COVID and were treated for COVID, in the fee-for-service population, we had 18,839 distinct members. You can see that the cost per claim at the beginning of COVID was dramatically higher, and we did see a decrease, but now that claim amount is creeping up slightly for our fee-for-service population. In the MCO population, we had 47,188 distinct members treated for COVID. The paid amount, again, significantly higher during the beginning of COVID, drastically reduced at the end of the COVID, or as not end of COVID. I wish we were at the end of COVID, but drastically reduced as the public health emergency has continued. Reimbursement rates, we did increase hospital and nursing facility rates because we know that they were on the front line at the beginning of the pandemic. Nursing facilities, we also provided, the cabinet provided testing and personal protective equipment for those facilities. The hospitals, we added an add-on to their DRG for individuals who were COVID positive. For nursing facilities, we did add a $270 per day for COVID positive patients. We extended their bed hold days, and we extended the due dates for cost reports. And then we currently have a $29 per diem add-on rate for all beds pending CMS approval. We did submit that in accordance with the bill that was passed. I'm sorry, I don't have that bill number with me right now, but we did submit that on time, and it is at CMS. We also submitted an Appendix K for a 1915C home and community-based waivers that allowed us to provide funding to providers for delivering services that they typically did not provide, such as home-delivered meals. Administrative regulations, as far as COVID-related goes, we did submit 907 KR 3300 to give us flexibilities during a public health emergency. And this regulation is not only good for a public health emergency, this will allow us to remain flexible in the event of a natural disaster such as flooding or a tornado. Also, we did at the beginning of the COVID public health emergency, we filed a recipient cost sharing regulation. We did have to pull that back based on a statute, and I would like to thank Senators Meredith and Senator Alvarado for Senate Bill 55 eliminating the co-payments for Medicaid members, and we are in the process of amending our regulation to reflect the changes in that bill. Here are regulations that we have filed since March of 2020 that are not COVID related. I didn't know if you wanted a listing of all those. I think in the essence of time, I can just leave those there, because I think, yes, now I'm at the legislative implementation update. So I will stop, take a breath, a drink of water, and take questions.
Thank you. Allow us to take a breath as well. A lot of information, very concise presentation. So I'll open up for discussion of the committee members. Anyone have any questions, comments? Senator Alvarado?
Just really briefly, Commissioner, thank you for that. It's a lot of info. And we saw the reimbursements. A lot of those tie into... did we see a market decrease in the number of actual visits, I guess is my question, in terms of visits by physicians, by nurse practitioners? I would imagine I saw the increase in the number of use for midwives and that sort of thing, as far as, and obviously during a pandemic, people probably felt more comfortable doing a lot of those deliveries in a home setting. So I would imagine those went up. But I'm curious about overall visits. Did we see an increase in mental health visits? Are there... The numbers usually will follow that, but not necessarily depending on the level of care. So I'm wondering if people, when they use telehealth, they're probably less comfortable to use higher codes, so they may have less reimbursement per visit. I'm just curious if the number of visits reflected the same drop that we saw in reimbursements.
We can definitely go back and look at that. We, based on what we're seeing, the number of visits increased with telehealth. Definitely, we did see a decrease in visits right after the public health emergency was declared, because individuals were not going into the offices, and it did take providers a little bit to get used to telehealth services and be comfortable knowing that they were definitely going to get reimbursed for those telehealth services. So we can go back and we can look at the number of visits as it relates to pre and post COVID.
Right. I'd be curious just in terms of, I know that a lot of I did telehealth, which again, we helped get that bill done, but I never thought I'd be using it myself, but I had to. And your billing levels, sometimes providers don't feel as comfortable billing a higher level because you can't do as much of an exam and you're very limited. So you often will bill a level 3 or a 2 instead of a level 4 kind of thing. I'm just curious if that would be nice to know. Did we have less visits overall with lesser charges, and that's why we saw a drop, or not? So that'll be something just out of curiosity. I'm just curious about that. Thank you, Mr. Chairman.
Thank you, Senator. Co-Chair Elliott, you have a couple of questions?
I do, Mr. Chairman. Thank you. I'm going to get the microphone over here. Good afternoon, Commissioner. Thank you for being here today. I wanted to draw your attention to slide number 5, I think it is. Ask you about the really the large increase in the number of people who have been eligible for Medicaid under presumptive eligibility. And I think if I'm looking at this correctly, in January of 2019, there were 2,549 individuals enrolled in Medicaid under presumptive eligibility. In April of 2021, that number was 131,833 under presumptive eligibility. Am I reading that correctly?
You are reading that correctly.
What plans, if any, does the department have to begin to work these numbers down in the form of those people who are no longer eligible? I know that the last year when you came before this committee, I think with Secretary Friedlander, I questioned the policy that was adopted at that time to automatically bestow, for lack of a better word, presumptive eligibility on many people who were on unemployment or who were eligible for unemployment. So and this is a long-winded question, what is the department doing to look at bringing those numbers down? Because I can't see that as being sustainable long-term.
So presumptive eligibility, as you can see in January of 19, we had 2,549. Presumptive eligibility has been around for quite some time. We had presumptive eligibility for pregnant women. So presumptive eligibility is a temporary Medicaid benefit for individuals who do not have health insurance and who have, they go to the doctor and they don't have health insurance. Presumptive eligibility is a way to get them into the program quickly and allow that provider to get paid while they're waiting on their full Medicaid application. So if you look at the total Medicaid population there in the just under totals and Medicaid, you'll see that our enrollment went from 1.2 million up to 1.4 million. Many of those individuals previously were in the presumptive eligibility benefit before they moved over into the full Medicaid benefit. So the department and the cabinet has been doing outreach to those individuals who enrolled into the Medicaid program to help them complete that full application to move over into the traditional Medicaid program. So we've increased our total Medicaid to 1.4 million. You can see, so we have been working with those individuals to move them over into the Medicaid program.
So how long is it going to take to vet all of these individuals to determine if they're still eligible? That seems like that would take a long time.
And
I assume, I'm sorry, go ahead. I didn't mean to.
Go ahead, John, if you had additional.
No, that's my point is how long is this going to take to go through and determine?
We do have a significant number of individuals, our connectors, who typically assist individuals with enrolling or reaching out to those individuals. We have some of our DCBS workers that are also working out to those individuals. Now, in the event that a presumptively eligible individual applies for Medicaid and they do not qualify, then they are discontinued. Once they have 2 presumptively eligibility periods in a year, they can no longer have eligibility. So some of these individuals, if they do not complete an application, If we can't contact them, for example, and they have had 2 presumptively eligible periods, they will be dropping off and they will not be allowed to come back on to the system within the year.
So is it possible that a significant number of these 131,000 people are not eligible? Is that possible? Right now as we speak?
We wouldn't know that unless we actually did the application process, because Medicaid eligibility is one of the most complex animals that I have ever seen, and I've worked with Medicaid for over 20 years. It could be possible that a few may not qualify, but in the event that we help them with an application, we would definitely make sure that they submitted an application on the exchange, because we wouldn't want them to go uninsured.
Sure. Well, just looking at the numbers, if we had 2,500 people prior to the pandemic, and now we've got an increase of 129,000 people roughly. I think it would be probably not an unusual conclusion that some of these people, or a large percentage of people, aren't eligible. But Mr. Chairman, I appreciate your patience.
Thanks, sir. I have 2 questions in my queue here, and if I could, I'd like to limit the questions to just those 2, because we need to move on. We got a lot of territory to cover. But first, we got a request from Representative Sheldon to offer a question.
Yes, thank you, Senator. Briefly, Commissioner Lee, thank you again for being here. Boy, it really jumps out at you, this chiropractor increase. You must have dived a little deeper into that. I'm just sitting there trying to think of what could cause something to go from, you can go back to that slide. I don't know whether I can't remember exactly. It was like 30,000 to like 1 point something million, or what was that?
So a chiropractor, it was 108,000 up to 1.5 million.
Yeah. I was just trying to think of what happens in a COVID that would cause that kind of increase, and was there certain procedures, or did that catch you as much off guard as it does me?
Yeah, I did look at it, and I think again that part of that is the lifting of the prior authorizations. Typically, individuals who get chiropractic services, I think they're limited to 20 per year, or 20 visits, and then they can only get more if it's medically necessary. So lifting of that prior authorization definitely probably had something to do with that, plus the influx of individuals who are now insured. But yes, it does jump out at you. So
yes, I kind of figured it was simply just the lifting of the PAs that did this, and that's a big jump. But got a lot of friends in the business. I didn't see that coming. So thank you very much.
Thank you, sir. Representative Mosier, you have a question.
Yes, thank you, Mr. Chair. Thank you, Commissioner. It's nice to see you. This was a very thorough presentation, but I do have a quick question. I'm just really going to follow up on an earlier question about presumptive eligibility. And in looking at slide 5 again, it looks like all of the folks who were eligible for Medicaid under presumptive eligibility, with the exception of 3,414 people, were eligible for Medicaid. So not that many people really are rolling off. Is it? I guess one of my first questions as a clarification is, what is the time period that individuals must apply for Medicaid after they are presumptively eligible? Is it 90 days?
No, they just have to apply before their presumptively eligibility period ends. If they don't apply before their period ends, then they will be discontinued.
But what is that presumptive eligibility period?
So the presumptive eligibility period during the public health emergency runs from the date the individual applies for the application, and it ends on the 2nd month following the month of application. So for example, if someone applied for presumptive eligibility today, they would be eligible today through July, through the end of July. If they did not complete an application, then they would be discontinued.
Okay, so not quite 90 days. Okay, do you have an overall cost to the state on the increase in Medicaid during this period?
specific to presumptively eligibility or the entire?
Well, yeah, I mean, the overall increase in Medicaid recipients, we had, an increase of 131,833 people here. I mean, those are not even unduplicated individuals who may have rolled off, but yeah, the cost to the state for the increase in Medicaid.
Yeah, we do submit quarterly reports to LRC related to all of the expenditures in Medicaid, including the number of individuals who are enrolled. I can make sure that I forward you the latest report that we sent. But if you want us to do the pre and post COVID, we can definitely do that, very similar to what we have done here to show the increase in costs. And again, the 6.2% increase in FMAP provided by the federal government has allowed us to remain in budget during this year.
Okay. Okay. Thank you.
Yes, Commissioner, I'd like to suggest that you pull those numbers together for us. I did receive the report for this last quarter, and by my very brief calculation, looks like our enrollment's up about 13.3%. And if we extrapolate the rest of this year, it looks like we're going to be up about 8.6% in expenses. But I think it'd be beneficial for the committee if we could do a deeper dive on this at a future meeting, because with the budget coming up, we want to know exactly where we are. If I could, let me conclude with a very brief question before you. Can you speak a little bit more on the issue of maintenance of effort that you spoke about earlier?
Sure. So a maintenance of effort is a qualification at the federal level that individuals who were enrolled in Medicaid at the beginning of the pandemic cannot move to a lesser level of eligibility enrollment, and they cannot be disenrolled from the program unless they are deceased, or they request to be disenrolled, or they move out of state. However, that maintenance of effort does not qualify to the presumptively eligible population.
All right, thank you. Again, committee, just a wealth of information here. I'm sure there's some other questions out there. I would recommend that each of you, if you have questions, send them to us, and we need to do a follow-up on this one at a future meeting, because, again, a lot of information. With that, I hate to cut the discussion off, but we still got a lot of territory to cover. Commissioner, if you would, please continue.
Okay. So next on the agenda is the legislative implementation update. And I think there were some specific bills. Well, I know there were some specific bills that you wanted us to address. So before I address those, I did want to talk a little bit about our managed care directed payment program. So with the MCO final rule, which is governed by 42 CFR 438, CMS basically states that if a state Medicaid agency directs an MCO to pay a specific amount of reimbursement to a provider, that's considered a directed payment. So what we have to do when we implemented Senate Bill 50, for example, and some others, we have to send a preprint to CMS. It's not really a state plan amendment, but it's a preprint saying this is how we are directing the MCOs to pay. This is what they're going to do. And CMS states we have to have quality measures associated with those directed payments. So it's not as easy as us just saying, okay, then you have to pay this MCO, you have to pay this provider type this X amount of dollars. For example, the 1064 dispensing fee that we're going to discuss with Senate Bill 50 is covered under that directed payment. So I just want to give a bigger picture, and it could be, maybe again at a future meeting that we talk a little bit more about those directed payments and how we can actually utilize those to drive quality. So with Senate Bill 50, and before I get into Senate Bill 50, I know that there was some noise this morning, maybe last week or earlier this week, that started about the 340B portion of Senate Bill 50. I heard that, we did have a presentation. We had been talking to the providers. There was a little bit of confusion that we were changing the logic for 340B pricing for the single MCO PBM. We are not. We are definitely in compliance with Senate Bill 50 as it relates to 340B. What we are doing is, since we are following the fee-for-service reimbursement logic, that fee-for-service reimbursement logic for 340B means that the 340B pharmacies will get the 1064 dispensing fee. However, the other criteria related to the acquisition cost is not applicable to the 340B pharmacy. So I wanted to get that out there before we get into this. But of course, Senate Bill 350 requires us to establish a single preferred drug list and a single PBM for each MCO. We did establish the single PDL back in January. You heard Dr. Parton say that there were a few individuals who were losing or who had some disruption in medication due to some differences between the pharmacy and the fee-for-service PDL. But we are straightening those out. We haven't heard a lot of information about that since we were first alerted. We did contract with the single pharmacy benefit manager, which is MedImpact. We contracted with them on December 31st. We will be transitioning all 6 MCOs to the single PBM on July the 21st. Again, we've been holding routine meetings. We've updated the reimbursement methodology to align with our fee-for-service program. The formulary is going to be aligned across MCOs for all Medicaid managed care lives. The PA and the claims processing is going to be via the one entity, which is MedImpact. We are aligning the pharmacy network. Pharmacists will have one BIN and one PCN group number for all pharmacy claims. We do have pricing transparency. DMS has determined the reimbursement. The dispensing fee, as I have said, aligns with fee-for-service. That will be $10.64. MCOs will continue to manage the medical benefit, for example, the physician-administered drugs and the inpatient services for individuals who require those medications. And MedImpact will manage the outpatient pharmacy benefit on behalf of the MCOs. Again, we've been engaging with the MCOs. We have had several webinars for providers. We are focused on our current prior authorizations. We definitely want to ensure that there's no interruption of services. We are implementing a 90-day no questions asked extension to allow time to update prior authorization information. We do have a uniformed preferred drug list, which will remain in place. If a drug is not on our PDL, it will follow the fee-for-service rules. We are developing a common MCO over-the-counter coverage list because currently some of the MCOs may cover different over-the-counter medications. Member and provider communications will definitely be going out prior to this change taking effect. And we have submitted our preprint with CMS. We are still having conversations with them. We do not anticipate any issues. They were aware that this was coming before we actually submitted it. Now, one thing, again, the MCOs do have a higher dispensing fee for compounds. Medicaid fee-for-service does not. So some of those pharmacists that have compound drugs may see a reduction in their dispensing fee for those compound drugs. Providers will receive payments directly based on their EFT information on file with Medicaid. If a provider uses a PSAO and that PSAO is on file as the pay to, then that payment will go to the PSAO. So I think that this is, again, this is a very, something that the entire country is looking at because we are one of the only state that is implementing a single PBM for our managed care organizations and allowing the department to set those rates and oversee the PBM, and the MCOs are paying the administrative costs for those. So I think that the big question as we go forward is how are we going to evaluate the impact of Senate Bill 50 on the Medicaid program? We can definitely look at expenditures. We can look at the number of enrolled pharmacies. On our quality measures on our preprint, we have access and provider network, how many providers will stay in the network based on these payments. But what else do we need to look at? And as we go forward, the preprints are good for 1 year. So as we move forward, what kind of quality measures do we want to put in place as we continue this process and continue to utilize the single PBM? So again, I would look to this committee to help us design some sort of report that we can get baseline data now, so that we can look at going forward to look at the impact of this program or this Senate bill, so that we can definitely tell how it's impacting the program. And again, when we look at this, we'll need to take into consideration Senate Bill 51, which removes the prior authorization for Medicaid assisted treatment for SUD. So how do we put that in there too? So again, looking to this committee to help us identify what you want to look at to see how this Senate bill impacted our program going forward. House Bill 8 is Ambulance Provider Assessment Program. This we have gotten approval. We received approval on March 31st to implement the Ambulance Provider Assessment Program. And this program is going to be, we'll use this to reimburse up to the available provider tax on Medicaid transports only for all Kentucky ground ambulance providers. So I think that's very important to note there. CMS did approve the preprint back to January 1st of 2021. We have it approved through December 31st of 2021. We're currently working with the ambulance providers and other stakeholders to finalize this and request an extension through 2022. Total estimated increase in reimbursement to these providers are $47.4 million. The estimated tax due from them is $7.7 million. And then March 25th, a provider training session was conducted by WebEx for these providers. The state share of the payments will be funded by the new provider tax. The tax is a flat 5.5% of cash collections. Gross revenues are reported only for transports originating in Kentucky. Their quality measures in this preprint are reducing ambulance response times and increasing the number of certified EMS practitioners. Again, quality measures that we can look at to help drive quality, and how do we look at those going forward year to year. Implementation timeline, the provider should see their first payment in June 2021, and the provider tax is due to the Department of Revenue in August of 2021. House Bill 183 is the Hospital Rate Improvement Program, HRIP. CMS did approve a revision. The whole purpose of this to move those hospitals to the average commercial rate for payment to increase the revenues generated for our hospitals. Continued goals of improvement include two metrics related to opioid use, given the magnitude of this issue in the state. So current e-prescribing and opioid-related adverse respiratory events. CMS has approved this, our HRIP program, retro back to July 1st of 2020. It is approved through June 30th of 2021. And the department's working with KHA and others. We did work with them to revise and submit a request for a 3-year approval process for the ACR that was submitted on May 11th. We did work with KHA. We collaborated with their leadership as well as our medical directors within the cabinet to establish what we believe are some very good concrete quality measures going forward. And we definitely look forward to evaluating this program and the impact it's going to have on not only for our providers, but our members. Implementation timeline, on April 15th, the providers received their first, their quarter one payment of $246 million. April 30th, they received another of $248, and we will be processing payments on May 26th for $250 million, and then again in August for another $250 million to the hospitals. House Bill 278, personal care attendants. Of course, this requires the department to accept employment of temporary COVID-19 personnel care attendants as meeting the training for state registered nurse. This morning, we have been communicating, the cabinet has been communicating with Ms. Johnson with the Kentucky Association of Healthcare Facilities. She drafted a communication for us to review that she thinks it would be necessary to provide clarification for providers, and we agree with her. We are looking at that communication and hope to get that out, finalized and sent to providers very soon. We believe we may need to do a waiver because of the requirements outlined in the federal statute. But we're still having a little bit of conversation about that to make sure that that's the way that we definitely need to go, because definitely looking at the communication in the bill to make sure that we understand the intent. And we just want to move forward and make sure that we are in compliance with federal regulations. So can give an update on that later if needed. House Joint Resolution 57 establishes a work group to assess the feasibility of implementing a bridge insurance program. Very excited about this work group. Our first meeting is to be held in July. We have sent out a poll requesting the members that are identified on this work group to respond so we can get that meeting on the books. And I think that with this work group establishing looking at the bridge insurance plan, I think that the presumptive eligibility population that we have been serving will be a good data source for us to look at. You know, if those individuals are uninsured, why are they coming into the program? What services are they using? And that could help us identify needs of a bridge program going forward. This is a listing of the work group members. And now I will stop there on the bills because we're at our next topic.
Thank you, Commissioner. I hate to throw you a curveball, and if you don't have anything on this, please feel free to defer on this. But can you give a brief update on House Bill 438, the single source credentialing?
I can give you an update. I believe that the single source credentialing has stated that we are to terminate our contract with the vendor that we currently contracted with. So we are in the process of fulfilling the obligations of 438.
All right, thank you. Appreciate it. Have a question from first Representative Sheldon.
Commissioner Lee, thanks again for your outstanding work on Senate Bill 50. Wow, that was impressive watching all those slides and everything you guys have done. And thank you for helping keeping me in the loop as well along the way. So thank you very much. Quick question. The methodology, first of all, yeah, the 1064 was a fantastic win. I think that was something that certainly is going to be great for everybody, and including the taxpayers of Kentucky. So we've been down that road. What I want to ask you specifically is, we had a PTAC committee, a Pharmacy Technical Advisory Committee, that presented what they felt would be the best methodology, and I quite agree with it. And it actually deals with the cost of goods, not necessarily the dispensing fee. And we've all spent a lot of time talking about the 1064, and we should have. That was the big number, right? But going back to the cost of goods, we were going to use, and we would just all throw around this lesser than logic terminology, right? Those of us in the business know what that means. And so I don't know very many industries that we say you can use the cost of our goods and you can take 5 different ways to figure it out and take the lowest one. I think that's, I just want everybody to know what that means. So we allow, obviously we're used to dealing with that with contracts. So that was something that even the PTAC committee agreed to. But what they didn't agree to, and I agree with it, is including MAC as part of your lesser than logic, because we already have NADAC, we have federal upper limit, FUL, we have WAC, WAC, wholesale acquisition costs, and we have usual and customary. We have 4 different ways to determine cost. NADAC was the most recently developed in 2013. It's used by 33 states. That alone would be enough to determine the cost. And oddly enough, out of the 5, the fact that you included MAC, again, that was not in the recommendation, that is the only cost of goods for drugs that PBMs actually get to determine and provide you a list of. So I can understand probably why they got put in there. And I'd like for you to consider, and I'll stop right here because this is a big, long committee and a lot of things. So I would like for you to consider, we have a month and a half. It's a push of a button I know it's not that hard. I think MAC is an archaic way of dealing with things. It's been around since the late 70s. and it really came from a federal program. There's a lot more better ways to determine, and NADAC is determined by, as you know, a database that is fed every day. And actually, I think they're going to use that in surprise billing for the doctors. So a very similar database. So I would like to see if there's any way you, me, and maybe we could have a meeting separately and talk about, what we could do about that.
Senator Sheldon, we sure can, Senator Sheldon. The thing about us going forward in the method that we did is ease of implementation. We were looking at what is the easiest thing that we can do to get this in place right now. And I should have said when I was giving that update on Senate Bill 50, this is our first step to reforming the pharmacy benefit program. We actually wanted to we were looking at a tiered administration fee. We really were looking at that, but the ease of it, we have to do a survey, we have to do all sorts of things. So we really look at this as the very first step in improving our pharmacy benefit, and we definitely look forward to meeting with you and talking about the future and what we need to do to continue to make these improvements. And again, this is the first step, and this was ease of implementation.
Well, I'd be glad to meet with you anytime. Just, you know how to get hold of me. So let me know. And I would love to get it done versus having to go through everything it would take to get it changed later. So, hopefully we can get that done, but thank you very, very much.
Commissioner Levy, I think we all appreciate the time and effort you put into Senate Bill 50, and we're glad to see it's finally come to fruition. I know there's still some concerns that we'll have to address over the long term. Only comment I would have is I probably share Representative Shelton's concern about MAC. I think one of the intents of this legislation is to increase transparency, and I think that muddies the water a little bit. So that's just an editorial comment, but I appreciate it. We have had some questions from the MCOs. I don't know that they're substantive in nature. One being that they're concerned about the July 1 implementation date. My thinking on that, it could be December 1st of next year, and it still would be too soon. But one of the things they suggest is this could be a challenge for people who rely on prescription medications. I don't see that logic. Do you see anything that suggests that that's going to be an issue?
I think that the MCOs, that you probably received a letter from the Kentucky Association of Health Plans regarding some of their concerns. We did respond to that. The department did respond to that letter, and while we appreciate them expressing their concerns, our viewpoint is we have a plan to move forward with July 1. We need to make that happen, and we expect them to participate, which they have been. They have been at the table. Their IT staff have been here, so we expect to make every effort to ensure that there are no disruption of services in this program come July 1st.
You made reference to that letter, and I'm reading it for myself. And the second point is a concern about maybe increasing the cost of the Medicaid program. I think that was very interesting in that, we saw from the very beginning that there's a potential savings of maybe $500 million by heading this direction. So I discount that issue, and I'd hope that everyone else would as well. I have a question from Representative Prunty.
Yes, can y'all hear me?
Yes.
Okay. Commissioner Lee, I appreciate your presentation, and just have a question for House Bill 8. I had a city council member approach me recently about the fact that they weren't going to be their ambulance service. They didn't know how they could keep going. Could they contact your office to see how the changes that are coming forward from House Bill 8 will affect them positively? Can they check with somebody?
Absolutely. And I believe that we have about 137 providers enrolled. So absolutely, they can contact me, or they can contact Steve Bechtel, who has been working.
Contact who?
Steve Bechtel. I'll send you his information. And I would be remiss if I didn't say that as far as Senate is concerned, that the hard work and the hard lift has been done by Senior Deputy Commissioner Veronica Judy Cecil and Dr. Fatima Ali. They have been very instrumental in making sure that goes forward. So yes.
Okay, and then the other request that I have for a future meeting is is Edinburgh currently right now. They have requested, and I would also like to have an update on how 108, House Bill 108 is going to be implemented for a future meeting.
All right. Thank you, Representative Prenti. Senator Alvarado.
Yeah, thank you, Mr. Chairman. Commissioner, just a quick question. I know whenever we've had new rollouts, anything that requires information technology or IT issues, when it comes to Medicaid, there's always glitches, obviously. And that's another thing I've heard from fears from a lot of the MCOs are worried about. Is this thing going to roll out? Are there plans for dry runs? Are there guideposts that we already have in place for that in terms of plans? If so, do we have any idea? I know when we've rolled things out before, there's always things that'll happen that we don't expect, but obviously the more that we have in anticipation of that July 1st rollout, are there plans for that, I guess is my main question.
Yes, we are doing testing. We will be doing testing definitely before this rolls out. We also have plans to have a war room basically when come July 1st, so that we can ensure that providers have a direct contact that they can call. Members can also call, so we can divert any issues as they happen. But I think that our 90 days, no question asked, PA, those kinds of things that we're putting in place as far as Senate Bill 50 is concerned, I think that we have a plan, and I think that we will be able to execute this as smoothly as we can. And there may be, as you've indicated, one or two hiccups, but we're doing everything that we can to prevent any unintended consequences.
Great, thank you.
Any other questions regarding this particular subject matter? If not, Commissioner, please proceed.
I think our next topic is a report on outstanding Medicaid waiver and state plan amendments. Our waiver, House Bill 352 in the 2020 session, of course, directed the department to create an 1115 for substance use disorder treatment for eligible incarcerated individuals. So we have, here's a timeline of that waiver. It has been completed. It is submitted to CMS. We are pending their approval. Hopefully we have been in contact with them. We've had a few meetings that they have had to cancel. I think they're going through some internal reorganization at CMS, but it is currently pending. Some current pending state plan amendments and preprints. We did make some changes to reimbursement for school-based services. This is part of the expanded care in school that allows schools to bill for services for Medicaid eligible children who do not have an individualized education plan. Currently, they're limited to to billing for prior to expanding, they were limited to. So this will allow them also to draw down some administrative funds based on administrative claiming activities. And they will also need to be submitting a cost report, which means they will be getting the cost of coverage for those, providing those services to children. We did submit a mandatory MAT coverage SPA. That was something that, even though we were covering it because CMS made some changes, we had to update our state plan. We did, you can see the case mix nursing facility rate add-on of $29. Program for the all-inclusive care for the elderly is pending. We do have a K-CHIP SPA. You've heard today from Dr. Parton about some of the issues related to maternal mortality. We believe that the K-CHIP SPA to cover pregnant women between 185 to 200% of the FPL would be very beneficial because these children are going to be eligible for K-CHIP as soon as they are born. We do receive an 80% in FMAP for those individuals, so we do receive a higher FMAP for those women. It's going to be a very small population, and we do notice, based on some of the individuals that have been coming into the program, we do believe that's something that we should move forward with. We do have a pharmacy preprint for 2019, 2020, and 21 that is associated with the $2 dispensing fee. We just had to get all of those to CMS and get those approved. They're still with CMS. Don't anticipate any issues with those. Of course, we've got the single PBM preprint, and we have a durable medical preprint that is associated with I think the MCO is paying 90% of the fee schedule for certain DME products. And so that, again, is a preprint. We had to have quality measures in it. Some of these are, seem to be maybe a little bit older, but that's because the preprint and the final preprint wasn't developed by CMS till a little bit later. So we are working through those. I can answer questions on any of that. And I think we have one more topic, but this is the end of my presentation.
Yes, ma'am. Any questions regarding Medicaid waiver or state plan amendment? Apparently there are none, Commissioner, so please, I'm sorry. Sorry, Representative Moser, didn't see you over there. Representative Moser has a question for you.
Thank you, Mr. Chair. Sorry, I was just looking down the list and wondering if you had mentioned the 1115 waiver for Medicaid during incarceration. Do you have any sort of update on that waiver?
That is still pending with CMS. So it was in the waiver. It was in the waiver presentation.
Okay.
There was a page before with the.
Sorry, I'm trying to keep up.
Okay.
Okay. Thank you.
Thank you.
There are no other questions. We'll continue with the very benign subject of Medicaid Managed Care Organization request proposal process.
So currently, the judge's order is not final. There is, I think, a hearing to be held June 3rd, and we will have more information or further when we get further direction from the court.
And I know this is a developing process, but do you see any substantive changes in the RFP itself whenever we approach this again?
Well, I think, anytime that we have to amend or we have to reprocure is an opportunity for us to look to that contract and, strengthen it in any way we can. And I think that it would be a good exercise and something that we would want to do very thoughtful and methodically as we move forward, rather than rushing to do the same thing that we have now.
I would hope so as well, and I'm sure my experience is the same as most of my committee members here, that I have a lot of anecdotal instances that question, the operations of our MCOs. Had one recently, not a constituent of mine, but from another district, that had a dental problem, and within his district, Humana had the only credentialed providers for this particular service, and when this patient tried to obtain those services, they said they would not accept Medicaid. So I guess my question is how do we monitor and how do we secure that there's an adequate provider base for these MCOs to be involved in this program?
They do have to demonstrate network adequacy through reports and through geo-access information. So if we have issues like that, if anybody calls and says they can't find a provider, they need to reach out to the MCO. If the MCO is of no help to them, then they need to contact the department, and they need to specifically, they can reach out to me so that we can help them.
I appreciate that. In this particular situation, of course, we're relying on email, but he said he had reached out to the MCO and asked, what am I supposed to do? And apparently their response was not our problem. So I appreciate that clarification, and that will help. But the other issue hanging out there is that we got some community health centers that do not have contracts with Molina, and they're providing the service, have been for some time, and they're building a pretty good accounts receivable here. And I think they're attempting to provide the service in good faith, but Molina doesn't seem to be negotiating in good faith. And so is that part of a consideration in awarding these contracts?
Yeah, it goes back to network adequacy, and they must meet network adequacy. I'm aware of some of the conversations with the community mental health centers and Molina. We have been involved in that to make sure that they can get those contracts secured. So if anybody has any of the providers have issues, they need to reach out to me. They can reach out by phone or by email. I am in the office, so they can reach out to me phone or email.
Well, my numerous conversations that I've had in these committee meetings always talking about being fair and equitable, and it just boggles my mind that an MCO will present a contract to a provider and say, here, sign it or else. And then when the tables are turned, you can't get them to come to the table. And supposedly one of Melina's issues is, well, we just don't have time to negotiate the rates on this. Well, if you don't have the time, that means you don't have the resources. If you don't have the resources, then maybe you shouldn't be a participant in this program. And I suspect, and I wonder if they've got some financial issues that they're relying on the float of not paying for these services to help them to continue their operation. So how much substance does financial viability play into awarding those contracts? And the reason I ask that question, I'm sure you read Humana's opinion or the response to the judge's original ruling that, fewer MCOs that are financially stable may be better than having a bunch of MCOs where you don't have that type of stability. So that's a concern as well. Do we look at financial viability of the MCO and their ability to continue service and actually pay the claims?
I believe that the financial viability is covered under the Department of Insurance's purview.
But is there a contractual provision to that effect?
I believe they do. I would have to go back and double check. I do believe that they do have to submit financial documentation to the department when they respond to those RFPs.
Well, I know why everybody hates to go through this process yet again a third time in less than 18 months, but I think it does force an opportunity to strengthen the expectations to the MCO. So, again, I'm encouraged to really look at the RFP and see if we can't tighten that up and get a good service. And last question I would have is the judge's opinion, which I have not read, but does it impact the single MCO for our foster care and child services?
I'm unsure.
Well, it seemed possibly the same logic would apply. That's why I pose the question. I don't know myself. But thank you. Senator Alvarado?
Thank you, Mr. Chairman. Actually, you asked, I think, a lot of the questions I was going to ask. So the foster care one was one. I think Aetna got that contract for foster care. So it would make sense if we're rebidding that probably has to get back on the table as far as being rebid. Commissioner, I know we've been aligned on the Medicaid getting rid of the copays for Medicaid. And so I would suggest perhaps, since the bill has been proposed by the chairman, at least for 2 sessions now in a row, to reduce the number of MCOs, that would be a consideration for this next RFP process. I think it's, there's quite a few of us that think that less would be better, and there'd be addition by subtraction. So it might be worth looking into that to consider at least that proposal, because I think it will probably likely come back again in the future for us. And if that's going to be something the General Assembly is going to consider, it might be worth having the cabinet in their next process to take a look at it. I do think this approach that the judges issued is the cleanest, really. I think it would have been a legal mess. I know we still have a lot of legal headaches, and you probably can't comment a lot on what's going on out there, but it would have been a mess trying to deal with letting everybody in. It was a bad message to have an RFP process and then not have anyone excluded. I think if we're going to do it again, I know it's going to take longer, it's expensive, but it's going to be cleanest from a legal standpoint. Be worth taking a look at, and we're going to have at least experience with all 6 of these MCOs for this past year to take a look to see how they've operated and how they've done things. And I think the Molina Care issue that the chairman talked about also, I think, is important. Just they've assumed a company, they've assumed Passport's debts, and they've assumed those contracts. They need to honor those contracts. And there's past payments that are due, some in the hundreds of thousands to millions of dollars to some of these providers. And they need to be able to come and make good on that if they've assumed that company's responsibilities. So I think that's important. And I think everything that these companies do in the next process, I know we take a look at past performance and how they've worked with the state, and that can affect the next contract. We'll have an example. And if they're not good players now in just a 1-year span of time, I don't expect them to be good players in the long run. So those are the 2 things I had. I think he asked them, it was the foster care issue, the Molina Care issue. And just to keep in mind, it's a recommendation we've had before about getting rid of copays. We passed it into law. We're considering reducing the number of MCOs. I would strongly urge you to consider that, to reduce the number. I think we can get the services we need to get accomplished for the state by having fewer and letting them know that if they're not going to play nice with Kentucky, that we don't have to do business with them if they're not going to honor their obligations. Thank you, Mr. Chairman. I appreciate it.
Thanks, Senator. I think it's interesting I made reference to Humana's appeal to the judge's original decision. And a lot of their arguments for not having 6 MCOs were the same arguments we presented in these committee meetings about it creates additional bureaucracy and expense to our Commonwealth. So, yes, we would certainly welcome that change. But also wonder, Commissioner, do we build ourselves in any flexibility that if there's another payment model out there, and they're all evolving, such as ASOs seem to really have a lot of interest right now. Do we have enough flexibility in our contract language that we could do one of those on a trial basis, experimental basis?
I think that I'll hold all comments until the judge's order becomes final.
That's fair. Appreciate that. Thank you. When that becomes final, I'm sure we'll have another discussion about this at this committee. So I thank you. Anyone else have any questions, comments for the Commissioner Lee? Yes, Co-Chair Elliott has a question.
Thank you, Mr. Co-Chairman. Commissioner Lee, is Medicaid working on a spending plan for the HCBS FMAP funds from the American Rescue Plan Act? And as I understand it, Medicaid has 30 days to submit that.
You are correct. We've actually surveyed some of our providers. We're working with our stakeholders. We have formed an internal work group because, Medicaid does work with our Department for Behavioral Health and our Department for Aging and Independent Living in order to administer those HCBS programs. So we do have an internal work group to look at all of the recommendations that we have received from our stakeholders and move forward, again, in a thoughtful manner on what's best for our members. We are not heavily considering any recommendation that requires additional funding because the HCBS FMAP is a one-time infusion. So we're not, again, heavily considering anything that would need funding in the future, such as additional waiver slots.
And a follow-up to that is, as you know, any spending plan or any spending of American Rescue Act funding requires legislative approval. So are you working through the process to get an informal legislative approval of that spending plan before it's submitted?
If we need to, we will. I was under the impression that these one-time funds were exempt from that plan.
Okay. I could be mistaken about that, but we probably need to follow up and see for sure.
We'll follow up. I think they're exempt.
If there are no other questions, comments, and Commissioner Lee, we certainly appreciate the amount of time you've dedicated to us this afternoon, and we continue to work with you going forward and building a strong Medicaid program for all of our recipients. And there's no other business. I'd like to remind committee members our next meeting will be June 16th at 3 o'clock. It'll follow the Health and Welfare Interim Committee meeting. So if there's no other business to come before this committee, we will stand adjourned. Thank you.
Thank you.